Okay.
Good evening, everybody. I am Dr. Josie van Londen, a medical oncologist at the University of Pittsburgh Medical Center. However, at the current time, I'm on medical leave for a neurological disease, which explains why my voice may sometimes hesitate. It's also the reason why we're recording this for future purposes if my voice doesn't cooperate moving forwards. I'm very happy to see all of you here. And usually what I say at the end of each lecture, if you have trouble with any of the things we just went through, I would usually suggest you come and see me in the clinic, but that doesn't work at this current time. So I will have to individualize the referral recommendations. And so perhaps if you have any needs or questions, I would suggest you contact the facilitator who can then, you know, connect with me and see what may be the best move, referral suggestion in your particular case. At the current time, and this is in November 2022, the survivorship clinic at UPMC is not reopened as of yet, since I stopped working there, as mentioned. So let's, without further ado, let's start with partnering with your medical team. Colleen, can you move the slide? I don't know if you can. Okay, thank you. These 5 essential elements of follow-up care make sense to you. They're very intuitive, and you're wondering, why are we going over this? And the reason for that is because in many places in the United States, these 5 essential elements of care are not routinely addressed. And so that's why official large organizations have named these 5 essential elements of care, and we are raising awareness for the fact that these 5 essential elements of care need to be addressed at every post-treatment follow-up visits, and we're raising awareness both at the level of providers, but also at the level of you as a survivor. And I guess my main theme for tonight is to empower you, to make you feel comfortable, to ask questions. You're not a pain in the tush. So the 5 essential elements of care are surveillance, to watch for recurrence of your previously diagnosed cancer, screening testing for newly diagnosed second cancers, health behaviors or lifestyle, care coordination, and assessment and management of any post-treatment needs. And we will go through each one of these step by step. Next slide, Colleen. So why these 5 elements of care? I think we just went through that, but the bottom line is to improve your quality of life, but also your quantity of life. And with that, adherence is very important. Adherence to anything from medications to whatever a provider tells you to do. But often it's difficult on patients' end to follow through with things. And that's, again, the main theme for today's lecture is we want you to feel comfortable to speak up when you have trouble doing something that your providers would like you to do. Next slide, please, Colleen. Next slide. So surveillance, to watch for the possibility of your cancer reoccurring. That's a very hot topic and one of the biggest concerns of many cancer survivors. In particular, as over time, our surveillance of you may decrease. The amount of visits that you have with us will lessen over time. The amount of testing we will do will decrease over time, at some point even stop. And you may also notice that from the get-go, some testing that you're asked to do, for example, blood work or imaging, may be totally different from somebody else who survived cancer, and maybe even the same cancer type. And that is because your schedule is tailored to you and your needs. It takes into account the type of tumor, and within the same tumor type, the aggressiveness of the tumor, as well as your other comorbidities and the treatments you've gone through. And sometimes doing more surveillance is not always better. Sometimes less is more, because testing such as scans is associated with a copay, is associated with radiation exposure, and lots of stress before, during, and after the tests, waiting for the results. And to tell you the truth, we don't really know if this frequent testing really helps detect a recurrence early. Somebody at some point just picked a random number and decided this is how often we're going to do surveillance testing with which scans. There is one tumor type where we have a large degree of evidence, and that is breast cancer. For breast cancer survivors who are in remission, there is a large degree of evidence saying that proactive checking for a recurrence with blood work or CT scans or PET scans does not help your outcomes. Now, this is different from doing your mammogram if you're a breast cancer survivor, and different from doing your office visits. But I'm talking now about specific tests to see if your cancer has reoccurred through blood work or scans if you're a breast cancer survivor. Next slide, Colleen. Next slide. So cancer survivors feel a lot of pressure on themselves, in particular if they end up doing less testing and less office visits with us. They feel a huge pressure on themselves to assess what's going on in their body and to figure out what it is, and if and when they should call us. And then who is that us? Is that your primary care doctor or your cancer doctor, or rhetorically speaking, really both? And your PCP, this is a pitch for me to advise you to stay in touch with your primary care doctor, because your primary care doctor may not even know that you had a cancer diagnosis and went through cancer treatment. And that is on us, the cancer providers, that we fail to communicate. But most of the time, it's just a matter of a simple box that we forgot to check when we're signing our notes. And if we forget to check that, the letter doesn't go to your doctor proactively, and he's not being informed of everything you've gone through. And so I would suggest to let your primary care doctor know one way or the other, even if it's just a short message, what you're going through. So that person is aware and can proactively help you with many things. One of them is your medications. Cancer doctors do a very good job of putting you on tons of medications to pull you through the cancer treatment. But then once your cancer treatment is done, we sometimes forget to turn them off and stop them. And your primary care doctor can help reconcile your medications and see if any of them can be decreased or stopped. And sometimes what we do may increase your risk for diabetes or for high cholesterol or for your thyroid going out of whack. And your primary care doctor is one who can help us keep those things on track. Next slide, Colleen. Next slide. So, but I suggest you also program the phone number of your cancer provider in your phone. And the reason being is that that person might be the person you call when you're worried if you have a cancer reoccurrence, because your cancer doctor might be more comfortable to decide whether or not your symptom could be related to cancer reoccurrence. So many of you have lost trust in your body after you've completed your cancer treatment. You may experience completely new things, you may have numbness in other areas. And so it's very hard for you to trust your own body and to know what is normal for you and what is not normal. And so many things throughout the day, the week, the month may trigger you to be concerned. Does this mean that I have a cancer reoccurrence? And so this slide illustrates a framework that may help you understand and feel empowered when to call who. And so it starts with non-acute symptoms, meaning if you have an acute symptom, like you think your appendix burst or you have a heart attack or a stroke, I would say, please call your doctor right away and have them deal with it accordingly. But if something doesn't seem to be urgent and you've had these symptoms before, but now the symptoms are different, or you've never had these symptoms before, but meaning they're new symptoms and they last for 1 or 2 weeks, then I would say at that point, call your cancer doctor. I would prefer you don't Google, but call your cancer doctor. And your cancer doctor may tell you 3 things that fall along the lines of a spectrum. One of them is your cancer doctor may tell you, this is probably not cancer related. Please call your primary care doctor and have him or her figure out what this is from. Or on the other end, they may tell you this is a little, concerning. We need to do some further testing, and why don't you come to the office and we'll go over the results, but hopefully everything will be clean. Most of the time, my experience is that your situation falls in between these two, meaning your symptoms are not specific enough for us to label it with a diagnosis. Doesn't mean we're telling you we don't believe your symptom, but it's not specific enough at this point in time for us to label it. In which case we would treat you symptomatically. For example, if it's pain, we would give you pain medications and regroup in a few weeks, let's say a month. And most of the time, in my experience, the symptoms will have resolved, which means it's likely not from cancer because it wouldn't have gone away without an intervention. And hopefully this framework will allow you to form a team with your provider where you know what's happening with your body, and your cancer doctor or your cancer provider, it can be a nurse practitioner, physician assistant, or sometimes even a nurse, can help you make sense of it so that you don't have to carry the burden of trying to understand it and Google overnight. Does this make sense? If not, please let me know and we'll go through it at the end of this recording. Next slide, please, Colleen. So the next essential element of care is screening for new cancers. And to go through that, I usually outline the 3 levels of risk that exist, the 3 levels of cancer risk development that exist. My late mentor used to explain it in this way. The lowest risk of developing cancer is for the general population out there who really haven't had a cancer diagnosis before. The highest risk on the other end of the spectrum for developing cancer is for those who have a known gene mutation that runs in the family from one generation to the other. They have a very high lifetime risk of developing cancer. But at the same time, we also have a cookbook of instructions that we can give them to try to reduce their cancer development risk by as much as we can. Now, there is a huge gray area again in between these two ends of the spectrum, and many cancer survivors fall in that in-between area. Their recurrence risk is not as high as a gene mutation carrier, but higher than the general population because they've had cancer once, which indicates that maybe their body is at a higher risk for developing cancer again. And so many cancer survivors ask me, what am I supposed to do now moving forwards? And frustratingly for both the survivor and the provider, we often can only say to them, we need to be on top of the general population guidelines. That's all we can offer at this point. There's no evidence that we can do anything more that will make a difference. And so that's all we can do. Stick to the gender and age specific general population guidelines for prostate cancer screening, colon cancer screening, skin cancer screening, breast cancer screening, and be on top of that. And that's all we can do. Plus, you would come into the office and tell us what you've observed, and then we can just help you decide if we need to intervene, if it means something else is brewing. The skin exam, I think, is one that is often overlooked. The skin is your biggest organ of your body, and it's usually a bigger burden to travel and sit in the waiting room than to have your skin check done from top to toe. But that makes a very big difference. Again, your skin is your biggest organ. It's worth doing an annual skin check. Next slide, Colleen. The third essential element of care is your health behaviors or your lifestyle. I'm not going through this in detail, as you have nutritional lectures and Jeanette Poppenberg, who will fill you in the respective details. But what I hope to do is give you sort of an overview to allow you to hopefully find your own balance that is right for you. And why am I saying that? Is because some cancer survivors, as a reaction to their cancer diagnosis, tend to overdo their health behaviors. And I'm not kidding. I had a few cancer survivors come through who only lived on lettuce, and others who've lived healthy their whole life and developed cancer decided it obviously doesn't matter. And so they were only resorting to fast food. And obviously neither of these coping mechanisms are ideal, but something they needed to go through in terms of their grieving and coping process. But it's our task to help you find the balance that's right for you, because lifestyle at the end of the day is not the only thing that determines your outcome. There's so many more factors in our body, the black box, that we still don't understand, that determine our outcome. That lifestyle is just a very tiny component of it, but one we can control. And cancer survivors often like to find things that they can control after a cancer diagnosis, when they've often felt things were outside of their control. And so lifestyle is one of them. It's one of the few things you can control, but with moderation and variety. We still don't understand exactly which lifestyle interventions will be helpful for a cancer survivor. We're extrapolating them from the general population. And so until we understand more, we suggest moderation and variety. And what I mean with that is shake things up. In terms of variety, don't do the same thing every day in terms of your exercise, in terms of your eating. Shake up the colors, shake up the grocery store even. It's good for your psyche. It may also be good for your health because you might be exposed to different toxins if they have different suppliers. Whatever you do, start low and go slow, and something is better than nothing. It used to be, evidence used to indicate that, for example, exercise needed to happen at least one episode, needed to have at least 10 minutes of exercise for it to be having an impact on your body. But now we're understanding that that minimal 10-minute threshold is really not that important. Something is better than nothing. And so count all those little bits together, and it doesn't always have to be exercise. It can be fun. I had quite a few patients who are into ballroom dancing, and chores such as raking leaves or doing grocery store shopping is also an exercise. And so before you know it, you will have your half an hour per day of exercise in, and you don't have to necessarily go out of your way to do so. Next slide, Colleen. So one other frequently asked question I get are supplements. Cancer survivors, again, want to try to regain control over their body, over their life. And one of their ways that they're doing that is to try to take supplements. And I'm a little bit conservative. Partially evidence driven by the fact that there was a large publication in a very good journal a few years ago that showed that those individuals who take a daily multivitamin lived shorter. This was an association, not a cause and effect relationship. And so this was surprising, and we're still, as of right now, trying to understand why that was. Is that because individuals who take the multivitamin usually have an underlying illness? Healthy people tend to take supplements less. So is it that these individuals lived shorter because of their underlying illness, or because a multivitamin, for example, that contains more than 100 plus ingredients, sometimes at supratherapeutic dosage with a carcinogenic filler in it, is that somehow doing something harmful to your body when you put it inside of your body? Who knows? And we're still trying to understand, but until we understand better, my motto in life is, when you don't know what to do, don't do anything. But that means if I don't understand what these supplements do, I prefer not to take them. I prefer to get my vitamin intake through diet. This applies to things that are over the counter that you take on own initiative. If we as a provider tell you that you need to take a supplement, whether it's a multivitamin or B12 or vitamin D, then I strongly suggest you follow that, because there must be a reason we tell you that, either because your blood level for any of these was low, or because you're at risk for malabsorption and your body needs a little bit of extra help to overcome. So bottom line is, we used to think that multivitamins or supplements don't harm and they may help. Now we're thinking they may harm and they may help. Next slide, please. The fourth essential element of care is care coordination. There's so many things that all of you and I are trying to balance, from your work to your private life, to your house, to your garden, to your family, to your finances, to your legacy, including now you need to exercise and eat healthy, as Jeanette and I have been telling you, and you feel like you need to sleep. But then also in between, maybe you should focus on healing. But there's very little time to do so. And so that brings a lot of stress, a lot of pressure. And I'm here to tell you that it's okay for you to schedule a little bit of time in your everyday to allow yourself to heal in a way that is healing for you. Whatever way that is, no judgment made. Find one thing in your day that allows you to recover, allows you to rest, something maybe that makes you smile. And secondly, one thing that may help is don't feel bad to bring it up with your providers. Say you're overwhelmed. Maybe they can help you prioritize which testing, which appointments should come first. Maybe some of your providers you don't really need anymore. Instead of seeing 3 in a week, maybe they can be distributed better, or maybe there's some duplication going on that you can discuss with them and see how to reduce that a little bit. And that may ease up your schedule and make your life a little bit easier. Next slide, please, Colleen. Okay. So I think this is a good slide for me to remind me to stress the fact that this period in your life has a lot of uncertainty. You're not sure what will happen. It's overwhelming. Lots of things are changing, and no need to be ashamed. This is another thing you can bring up to us. And even though we may not be able to help, we can send you to somebody who can help. Sometimes a little bit of talk therapy, sometimes a little bit of medication or a combination, just a little pushing you back may put you back on the right track so that you can resume your life the way you would like to. And maybe here I can insert a little bit of my philosophy on time. Many cancer survivors tell me that they feel like they've wasted a lot of time going through cancer testing and all the cancer treatments. And then they feel like they're running out of time because they're not sure how long they're going to be on this planet. And so there's a big time crunch, a big pressure to get everything done like yesterday. And my philosophy is that time is very interesting because as you move into the survivorship phase and you start to heal and you start to reflect and you give it some time, your priorities may change. Your life may totally change or it may not, but your perspective will likely change. And with that, you will make different decisions and you will catch up on time, if not come out ahead. And that, hopefully, that observation will give you some peace of mind, will give you some reassuring perspective that you're doing everything that you should be doing at this stage. Just give yourself a pat on your back, allow yourself to take a breath and step back and see as an overview what you've been through and where you would like to go next. Next slide, please, Colleen. So how to communicate with your team. One of the things that I think I'm preaching to the choir here is write things down. Even I think I will remember things when I need to remember them, but I don't. I write them down in my phone. Others may like a pen and a paper, whichever method works for you. Write things down. And when your appointment comes closer, maybe you review everything you've written down so it's fresher in your mind. And maybe select 3 things that you would like to discuss at your doctor's office visit, because probably more than 3 things might not be realistic in terms of getting them answered. And you don't only need to ask the doctor, you can ask the nurse practitioner, physician assistant, sometimes the MA, or even the nurse. They all can help you answer your questions. And hopefully over time, you will get all your questions answered. All concerns are legitimate. You're not a bother. And sometimes, I think that's on the next slide though. Next slide, Colleen. It's not, but let me tell you, sometimes it's helpful to bring somebody with you to the appointment. An extra set of ears, they may help you listen for when you're still processing 2 sentences before, and you're tuning things out, or maybe you've understood it differently than the person you brought with you, and that allows you to settle on your differences. But if even bringing somebody with you doesn't clear up any misunderstanding, I would call your provider and say, hey, I'm not sure I understood this correctly. And they can answer you through perhaps the patient portal or through a phone call, or maybe even have you come back for an extra office visit to clear things up. If over time you continue to find that you cannot get your questions answered, then I would bring that up as well as a concern. Your provider may not be aware of the fact that you have unanswered questions. And depending on how they respond, you can decide if you feel comfortable with their response. They might say, oops, I didn't know this. Let me call you tonight, or let's come back next week into the office and we can go over all your questions. Or maybe this provider is not the one for you. It's just another relationship between a patient and a provider, and not every relationships are meant to be. So maybe even though you trust them, maybe hopefully there's other providers in that same clinic or in your environment, surroundings, that you can switch around if you really have to. I'm giving you permission to think about what you need and if you're getting what you need. If you Google online, first of all, I would minimize that as much as you can. But if you do, you can go to websites that end on .gov, .edu, and .org. These are the most reputable and reliable and updated resources. The exception on that is www.cancer.net. It's a website set up by our professional organization, the American Society of Clinical Oncology, and for some reason they end on .net, but they're very reputable. Next slide, please, Colleen. So this is a very important one. At the 11 p.m. night news, many of you at some point may have had people call you, and family members or friends with well-meaning advice about something they have just heard or seen or read online or on TV, unsolicited advice that they feel is helpful, but may actually put you really in a stressful situation. And one of the things I would like to tell you is that cancer care will continuously innovate and grow. And most public alerts that all of you see online or on the TV are either way ahead of time, such as new cancer therapies that are not ready for prime time yet, or way behind on the facts, such as side effects that we are often already aware of way earlier than it gets announced in the media. And so that hopefully will allow you to take a breath, take a pause, and think about it. And feel free to call your doctor's office the next day and ask them, hey, I heard this. What does it mean for me? And most often it means very little to nothing. But it's perfectly okay to say to these people, you know what, thank you for telling me, but I don't want to hear right now. Or maybe ask me the next time before you tell me. Next slide, please. So another thing that is very often the case is you've gone through a cancer journey and now you're being deemed an expert. Just like when medical students go in training, they see one, they do one, and they teach one, and now it's your turn. You're thought of as an expert. And so whenever anybody in your surroundings has been diagnosed with cancer, they may call you for questions, advice, and support. And it might be a meaningful activity for you, but make sure you're in the right state of mind. Otherwise, you're not helping yourself nor the other person. It's perfectly okay to say, I cannot do this right now, maybe later. That's perfectly fine. They will find somebody else to help them, just like you found somebody to help you. Next slide, please. So assessment and management of post-treatment effects is a whole big topic. I will give here some general ideas, and then maybe we can drill into it in further detail in the Q&A. There are many post-treatment effects that you may experience that are too many to name, that can all happen at the same time. That might be emotional in nature, functional, physical, financial, and also here, there's very limited evidence to say how we should manage these particular needs in cancer survivors. So we extrapolate from data from the general population. For example, we have lots of data how to help face hot flashes and night sweats in the general population, but we're somewhat limited in how to manage them in the cancer population. So we use literature from the general population to see how we should manage these in cancer survivors. And because we do that, I feel that there is room for shared decision making, that there might be multiple ways in which to help a symptom, and that we can find a way that fits with who you are and how you live. For example, some cancer survivors are busy running their life, and they don't really have time for anything else. And they may prefer to take a pill, pop it, and move on with their day to get symptom relief. Others may feel like they don't want to put anything more toxic in their body, and they prefer to go out of their way to do something that might be more time consuming and more costly, but not as toxic, pharmacologically speaking, such as exercise or talk therapy or acupuncture. And everybody decides for themselves. Ideally, we try to find interventions that hit multiple symptoms at once, so that we ask you to do the least amount of effort to find relief. And it's important to know that some of these post-treatment effects might be asymptomatic until you develop a problem. For example, bone health. You might be slowly losing your bone mass that you don't notice until you break a bone when it starts hurting. And so for that, there's an important place for the primary care physician who can help all of us, including cancer providers, to keep an eye on your bone health by, for example, ordering a bone density scan every 2 years. Next slide, please, Colleen. So here are some of those side effects. This list obviously doesn't end. It's not exhaustive, but it's remind me to tell you that some of these side effects might start early and some may not start late, such as bone health issues. Some post-treatment effects might be short-lasting, some might last for a while, and some might be asymptomatic and some might be symptomatic. Next slide. Next slide, please. So this slide is to remind me to tell you that if you feel like you need a little bit of help to resume, in this case, exercise, or to start exercise if you've never done it yet, that's perfectly okay to do it under supervision of a physical therapist or a personal trainer, in particular, if you have any of the symptoms listed on this slide here. Either your primary care doctor or your cancer provider can make a referral. Next slide, please. Speech therapy can help with speech and swallowing issues that you may have developed after cancer treatment. Occupational therapy can help you regain your function at home or at work, and physical therapy can help you regain your ability to move around in your house and at work. And a personal trainer fills the gaps in between and further builds up your fitness level. Next slide, please. There we go. Oh, and then an exercise physiologist, that is one that needs a prescription, just as physical therapy, speech therapy, and occupational therapy. But exercise physiology is usually at this point only covered by insurance if you have a heart or lung issue, and they have a very intense, closely monitored fitness program to help you get back on your feet, where they monitor your heart and lung function while you exercise. But again, your primary care doctor or your cancer provider should be able to help you navigate which referral might be the most appropriate for you. Next slide, please. I think this means I am done. So Colleen, I think maybe we can stop the recording. But again, if you have any referral needs, let the facilitator know what your issues are, and then I myself or my colleagues can help you sort out which referral might be the most appropriate for you. And then let's now head over to end the recording and start the Q&A.